Thanks, Will, for such a warm introduction, and it has been such a pleasure working with you now for almost 10 years. And I thank the board for inviting me to speak today. And I would be covering updates and mostly cholestatic liver diseases. There has not been much on autoimmune liver disease. I think there were many studies covering natural history and outcomes in autoimmune hepatitis, but I'm going to focus on drug development and emerging therapies in PBC and PSC. So the first part would be updates in the treatment of primary biliary cholangitis. I would be covering the 5 years open label extension study of Ocaliva. I think we had an update on Ocaliva this morning prior to starting our session. I'm going to be covering some, but I will try to make it more abbreviated in focusing on the data that was just recently presented at ASLD, which will be the outcomes for their 5 years open label extension study. I will then be covering CILOFEXOR and PBC, which is non-steroidal FXR agonist versus Ocaliva is steroidal FXR agonist. So there's a difference between the two, and we'll cover the roles of that and PBC. PPAR agonists have been studied extensively in cholestatic liver diseases. And even though there has not been new data at ASLD, I think it's important to go back and review some of the recently published studies covering their role in PBC and PSC. There was a very interesting abstract that covered triple therapy for PBC that would be urso plus Ocaliva and adding bezafibrate. As you know, we currently can enroll patients that actually have not had adequate response despite adding Ocaliva. So this is a good study that shows that there might be additional benefit by adding bezafibrate. There was a study that covered pruritus, role of treatment of pruritus with bezafibrate, the FISH trial. And then briefly we'll go over some of the interesting studies that were presented regarding the treatment of PSC. And I will go back and review some of the old data on the role of Ocaliva on PSC. There was a phase 2 study that was presented a couple of years ago. And we'll cover what has been already published on the non-steroidal FXR agonist, CILOFEXOR, and PSC, and a study that showed improvement in PRO, meaning patient-related outcomes. And lastly, I will cover the role of mirvetuximab, which is ileal bile acid receptor blockage antagonist that actually will inhibit uptake of bile acids or reabsorption of bile acid from the ileum, and it is a role in PSC, particularly treatment of itching. So just a brief background about treatment of PBC. So the goal of treatment of PBC is twofold. You know, number one, treating the underlying disease process, which is the destruction of the small intrahepatic bile duct. And the second one is really geared towards the treatment of symptoms that are secondary to cholestasis. Those symptoms include pruritus, fast-soluble vitamin deficiencies, and osteoporosis. And lastly, prevention and treatment of portal hypertension, since patients with PBC actually tend to get early portal hypertension. I think it's good to be aware when to screen and treat. In terms of suppressing the underlying disease process, as we all know, urso is the first-line agent. 13 to 50 milligram per kilogram per day has been shown to be cholinergic, meaning improving bile flow, and it has shown to prevent progression to end-stage liver disease, improve survival, and it is definitely well tolerated with minimal side effect. The extent of the extent of biochemical response to URSO during the first year of treatment is actually a useful marker in predicting prognosis for patients with PBC. And we roughly think about around 40% of patients actually have suboptimal response to URSO. And so we have to think about additional treatment for them. I'm not going to cover this in detail, but the recent updates in the management of PBC guideline by the ASLD recommends that we should actually assess biochemical response at year 1. I think some people advocate you could do it at 6 months, but I think the official recommendation now is to continue treatment with URSO for a year and then measure their degree of responsiveness or improvement in their alkaline phosphatase before you decide what to offer thereafter. There are multiple validated ways of measuring biochemical response. I'm not going to go over each one of them, but they are well studied and validated, and there are multiple, so it's kind of hard which one to use. But recently, particularly from the work by the PBC Global Group, there have been more updated and kind of strong and powerful predictors of prognosis, which includes the global PBC score, the UK PBC score, and others such as liver stiffness measured by FibroScan, stiffness at baseline, and change over time is actually predictive of outcomes. So we have many different tools that are helpful in figuring out who's at risk after you treat patients with URSO for a year. This is a nice study that was published by the Global PBC Group that actually showed that alkaline phosphatase 1.6 times the upper limit of normal and normal bilirubin after 1 year of being treated with URSO is predictive of outcomes in PBC. And they had a large cohort of over 4,000 patients. As you can see, the graph shows that there is significant difference in terms of survival between the two groups. This criteria is called the POISE criteria, which is what is used to design the phase 3 study in Ocaliva. So what are we going to offer our patients? So the second line agent that's actually approved is Ocaliva. As you know, it is a derivative of the normal human bile acid, deoxycholic acid, and Ocaliva has a very potent affinity for the FXR agonist and actually the human bile acid, deoxycholic acid. And in terms of its role, that binding leads to decrease of bile acid synthesis, decreasing inflammation, as well as decreasing portal hypertension and fibrosis in the liver. So the POISE trial, which I think was presented earlier today, was an international multi-center phase 3 study. It included patients that were on uracilcholic acid for a year with a stable dose for 3 months, or patients that actually have not tolerated URSO. The inclusion criteria was the criteria that I just recently mentioned, which is alkaline phosphatase 1.67 times upper limit of normal, or bilirubin greater than 1 times upper limit of normal, but remain below twice the upper limit of normal. And their primary endpoint was achievement of alkaline phosphatase less than 1.67 times the upper limit of normal, with a 15% reduction from baseline in a normal bilirubin level compared to the placebo. I think you guys saw this graph earlier. This is a graph that shows their initial double-blinded phase of the study, which is a year, followed by the open label extension. This goes to up to a year. This is the data that was published on the New England Journal of Medicine article. And the response rate for placebo was 10% versus 47% for the patients that were initiated on 10 milligram and stayed on 10 versus 46% for those that were titrated up from 5 to 10. The difference was significant, and it was maintained till the year open label extension phase. In terms of most common adverse side effect of Ocaliva is pruritus, as you all know. What was interesting to highlight is that even though the rate was high, patients that were started on 5, titrated up to 10 milligram, they actually have only 1% withdrawal rate or discontinuation rate because of itching. And when they looked at patients at the end of the first year open label extension phase, the itching actually did improve down to their baseline level, and it was categorized as being mild. So if they stay on it, it actually may improve with time. Definitely, we need to be aware of the fact that dose adjustment is needed in patients with hepatic impairment. The metabolites of Ocaliva have been found to be significantly elevated in those with child B or C cirrhosis. In the insert or prescription guideline is to start at 5 milligram weekly in those with child B or C cirrhosis, but titrate up at 3 months to 10 milligram BID. And we really have to think about the benefit versus the risk of continuing this if patients are actually decompensating. So coming back to ASLD this year, so the group presented their 5-year open label extension data, which actually showed that the response rate was maintained through the 5 years time frame with 46% at year 1 met that primary outcome criteria, and 50% at the end of the 5-year open label extension phase maintained their response rate. As we can see on the second graph, the level of improvement in alkaline phosphatase was maintained through the end of that 5 years. And when they looked at safety profiles, this is just another table showing that the improvement and reduction of alkaline phosphatase, bilirubin, AST, ALT, GGT was maintained through year 5. And in terms of liver stiffness, there has not been any progression of liver stiffness since day 1. There was no improvement reported, but certainly there was no progression of disease over 5 to 6 years period, which really shows that there is long-term efficacy with using Ocaliva. In terms of discontinuation rate, they initially included 193 patients in the open label extension phase. 116 completed the study. They had 8 patients, which was about 4% that actually discontinued due to pruritus. Adverse events were actually the same as what we have seen in the initial randomized control trial. No new adverse event was reported, again, suggesting that Ocaliva treatment resulted in sustained improvement in liver biochemistry up to 6 years of follow-up. So the second class of drug I want to review in the treatment of PBC is CILOFEXOR, which is the non-steroidal FXR agonist. In this abstract number 45 was reporting its role in the treatment of PBC. So what's the difference between non-steroidal versus steroidal FXR agonist? You know, how are they different? The non-steroidal FXR agonist is not reabsorbed through the ileum. And so you can postulate that it may minimize risk of, it does decrease the degree of FGF19, elevation of FGH19, which is associated with increased bile acid synthesis and cholesterol synthesis, and hence by being non-steroidal, you may not have as much pruritus, and you may not have as much elevation in the level of cholesterol which are the two adverse events that we worry about in the treatment of Ocaliva. But it also has a significant affinity to the FXR agonist, which is located in the intestine. So FXR agonist, I think we reviewed that earlier, is involved in bile acid homeostasis. And so accumulation of bile acid definitely is hepatotoxic and can lead to progression of fibrosis in patients with PBC and PSC. And the GS9674, which is CILOFEXOR, that was the original name, has a small molecule with high affinity again, and has been shown to have anti-inflammatory as well as anti-fibrotic properties. Is shown to decrease portal hypertension, and also is shown to be anti-inflammatory. I don't think we have time to go over the whole mechanism of action, but the bottom line is it does, so it's an oral drug, and then leads to binding to the FXR agonist, which is located in the bowel. That leads to a release of FGF19, which then binds to these receptors and inhibits bile acid synthesis, and also regulates cholesterol as well as glucose metabolism. And at the end, it will lead to decreased bile acid synthesis, increased export, and decreased lipogenesis. FXR agonist, the CILOFEXOR also directly leads to FXR agonist binding in the liver with upregulating of this gene, which then impact the role of these genes, leading to, again, decreased bile acid synthesis and export. It also, again, has anti-inflammatory and anti-fibrotic property. So the study, so this drug was initially studied in PSC, and I'm gonna review that briefly. But in PBC, again, this particular abstract looked at the role of CILOFEXOR in a phase 2 fashion, and they included patients based on the POISE criteria, meaning having alkaline phosphatase 1 times the upper limit of normal, bilirubin above 1, but less than twice the upper limit of normal after being on a year of UDCA. And they randomized CILOFEXOR 100 milligram 30 versus placebo in a 2-to-1 fashion for 12 weeks. And it definitely led to a reduction in alkaline phosphatase, GGT, ALT, bile acid, and CRP, really showing that there is benefit in the treatment of PBC. The most common adverse side effect was pruritus. Again, as the reported rates were about 39% for the 100 milligram versus 10 and 8% for the other two. Discontinuation rate because of pruritus was about 7%. This was in the higher dose group, but none in the placebo or 30 milligram group. Conclusion of this abstract was that CILOFEXOR did lead to improvement in serum biochemistry in patients with PBC. And we think that there may be a, hopefully a phase 3 study coming up, or I think they have a continuation of the phase 2 patients. So this might be a study that will be coming up soon as a phase 3. The next receptors or category of drugs that I was going to review was the PPAR alpha agonist. The PPAR agonist in their role in PBC. As we know, fibrates, which are PPAR alpha agonist, and bezafibrate, which is a PPAR alpha agonist, have been shown in open label studies as well as other studies to improve liver biochemistry as well as IgM in patients with PBC, and those that have incomplete biochemical response, and those that are naive. Again, another complicated table, but so PPAR a receptor agonist in human have different isoforms. So we have PPAR alpha, PPAR beta, delta, as well as PPAR gamma. Bezafibrate, which is available in the Europe, not in the US, have pan affinity for all. Fenofibrate, however, has more affinity for the PPAR alpha. And in terms of how do fibrates improve cholestasis, is that fibrates bind to the PPAR alpha, and that will decrease formation of the inflammatory markers via the NF-kappa B binding. It also inhibits the hepatic nuclear factor for leading to reduction of bile acid synthesis. It also helps increase biliary phosphatidylcholine secretion, leading to increased excretion of bile acid. So the BEZ-ERSO study was a phase 3 study that looked at fenofibrates and PBC. This was, again, European-based study, which showed that bezafibrate led to significant improvement in alkaline phosphatase, as well as other liver enzymes. On their analysis, 31% versus 0% of the placebo group normalized their liver test. 67% versus 2% normalized their alkaline phosphatase. So 67% being for those that were treated with bezafibrate. But there was about a 5% increase in creatinine. We worry about renal toxicities and fibrates. There were people that had reported myalgia, which was 20% versus 10%. And it was noted that it actually led to improvement in pruritus as well as fatigue. Then this led to the study of SELADELPAR and PBC. SELADELPAR, if we go back to the prior study, prior slide, has the, it is PPAR delta specific agonist, and it has been studied in multiple, initially a phase 2 study, which was interrupted because of elevated ALT and those that were on a higher dose. So they ended up designing a low dose phase 2 study, which was really positive. They had 5 milligram versus 10 milligram randomized to patients with PBC that actually they followed the POISE criteria. So the 5 milligram and also the 10 milligram did lead to rapid reduction in alkaline phosphatase. As you can see, by week 12, about 39% of those that were on 5 milligram versus 45% of those that were on 10 milligram had significant reduction in alkaline phosphatase. And in terms of proportion of patients that had less than 1.67 times upper limit of normal at the end of 12 weeks, about 82% in the 10 milligram group versus 45 in the 5 milligram group. And what was very impressive is that they had about 45% that actually normalized their alkaline phosphatase below the upper limit of normal. And then in the 10 milligram group, it also led to reduction of liver enzymes and inflammatory markers. Itching was not increased. There was a turn to improvement in itching, and they ended up proceeding with a modified long-term extension phase 2 study, and also a phase 3 study, which everybody was excited about, which closed within a year. However, last week we heard that the development of the drug is on hold because they found adverse unexpected events in the study that was in the NASH study at week 52. Some of the liver biopsy findings before versus the follow-up 52 weeks actually showed presence of interface hepatitis, bile duct injury, as well as concern for some vasculopathy. So they ended up halting their NASH study. there was a PSC study which was open that was also interrupted. And in terms of the PBC study, so they have the phase 3 study and the phase 2 open label extension study. Those are on hold till we figure out if this is class related versus specific to NASH versus certainly, seeing interface hepatitis plus bile duct injury. I feel a bit guarded about moving forward for patients with PBC. So patients are not taking the drug, but they are currently continuing the UDCA. We just need to learn more and decide what to do. So a very interesting abstract. I don't know if we have time. How am I doing with time? Okay. So there was a very interesting abstract that was presented at ASLD, which actually looked at what I was saying earlier. So you can, if patients don't have adequate biochemical response on urso, you add obeticholic acid. But what do you do if they actually don't achieve the response that you want? They do not meet criteria for most of these clinical trials. And this abstract actually showed that there is added benefit of adding fibrates on those patients that are already on dual therapy. So you can either, it showed that there was additional 27% decrease in ALK phos per year on those that were treated with triple therapy. And it doesn't matter if the Ocaliva was the first drug versus the fibrate was the first drug. The second drug added, there seems to be significant benefit. So in terms of next step, I think it's anticipated that there may be a formulation of Ocaliva with some form of fibrate, but with this new findings of the CIMA-BAY study with SELADELPAR, we just have to wait and see. There was one study using bezafibrate that actually showed significant improvement in itching in patients with cholestatic liver disease. This included patients with PBC and PSC. They were given this agent, bezafibrate, for 21 days and significant reduction in pruritus, 38% versus 12%. And the other drug that is being looked at in PBC is elafibranor. This is a PPAR alpha and also delta agonist. There was a positive study reported in a phase 2 study previously that showed that after 12 weeks, about 48% of patients that were on 80 milligram had significant reduction in their, they met the primary endpoint, and 40% those that were on 120 milligram versus the placebo. And they used again the POISE criteria in terms of proportion of patients that actually met that POISE primary outcome criteria was 67%, and those that were on 80 milligram versus 79% of those that were on 120 milligram versus placebo. And there is actually an upcoming phase 3 study for PBC, hopefully soon. So this is kind of a list of agents that are being investigated in PBC. I think we covered most of them. In the interest of time, I'm gonna briefly cover PSC. So who should be again considered for these agents? Those that have partial response or no response after being a year on UDCA. Those that are actually intolerant to UDCA, diarrhea, abdominal pain, worsening of itching, hair loss. I actually had a few patients that had significant hair loss. They couldn't take urso, that I had to think about another agent. And those with progressive disease, despite seeming to have improved ALK phos. So for PSC, we have no proven medical therapy. Currently, the primary goal is treatment of symptoms and complications. Liver transplant is the only cure, and it is offered for people with end-stage PSC or those with recurrent cholangitis that you can petition, or early-stage cholangiocarcinoma in selected centers with a protocol. UDCA has been studied the most in PSC. I mean, we can spend an hour arguing pros and cons of using URSO and PSC. However, I think there is something about alkaline phosphatase and PSC we should know about. A study, the Scandinavian, one of the studies that looked at the role of URSO and PSC was the Scandinavian PSC URSO study group. And the initial study was reported in early 2000s, and there was no benefit between URSO versus placebo in terms of outcomes in PSC. Even they did not show, this study did not show improvement in liver biochemistry. But later, when they followed these patients for another 10 years and looked at the degree of reduction in alkaline phosphatase, so they looked at those that had greater than 40% reduction versus not, there was actually a significant difference in terms of survival. So there is something about reduction in alkaline phosphatase that is actually important. The first graph showed placebo versus treatment, no benefit, no difference in terms of mortality. The second graph shows a response. This is a group that was treated with URSO. Response to URSO versus not, there was a difference in terms of mortality. But this is a very interesting graph that actually showed, regardless of being on URSO, the ones that actually improved their alk phos, despite not being on URSO, they had improved survival. So there seems to be something about responsiveness or improvement in alkaline phosphatase that is predictive of outcomes in PSC. So there was a study that looked at how about what happens if you actually interrupt URSO in patients that are on, that patients with PSC that have been on it stable for a year. Guess what? Their liver biochemistries all went up significantly. The Mayo score went up. Symptoms such as itching actually went up. And so the new thinking is that if withdrawing is bad, then we should we think about giving patients URSO despite not having a very strong data. So there is a proposed algorithm and how we can think about using URSO and PSC. You can, there's also additional data in those that have inflammatory bowel disease, particularly ulcerative colitis. Using a medium to low dose URSO is shown to decrease incidence of colorectal dysplasia or cancer, but these have been kind of case series type of studies, not randomized controlled trials. So I often offer it for those that have ulcerative colitis at initial diagnosis, and the dose that is recommended to be offered is 17 to 23 milligram per kilogram, which is a medium dose. There was one study that showed some benefit, including improvement in MRI findings, as well as fibrosis. But that study was not, we were not able to reproduce that study, but this is the only dose that has potentially some benefit. So you can offer it and then follow, I'm sorry. And then you can try it for 6 months. If they have improvement of alkaline phosphatase, at least 40% reduction, you can continue. And if they continue to have, even with the reduction, alkaline phosphatase is elevated 1.5 times upper limit of normal, then you can consider about offering them clinical trials. But you can try it, and if you don't see any response to URSO, I think you should discontinue, because then there will not be any anticipated benefit. In terms of emerging therapies for PSC, so this was an older study. This is the data that looked at Ocaliva in patients with PSC, actually, reported at AASLD in 2017. It had placebo versus 1.5 titrated up to 3, 5 titrated up to 10. And they reported the week 24 data that actually showed that Ocaliva was able to decrease alkaline phosphatase for patients with PSC. And there is currently ongoing open label extension part of this study. The most common adverse event reported is pruritus, as we've seen in PBC. Not sure if there would be any phase 3 study upcoming. I don't know what the future anticipated goal is from Intercept in terms of moving forward this drug in PSC, but it was a positive study, phase 2. The other study that was published looked at the non-steroidal FXR agonist CILOFEXOR and PSC. This was a phase 2 study. Again, in the interest of time, it was positive. There were improvement in alkaline phosphatase, AST, ALT, GGT, and some markers of inflammation. The most common adverse event that was reported was pruritus. Currently, there is a phase 3 trial that is recruiting patients with PSC. They also have extended their phase 2 study. I'm sorry, they also are starting a phase 2 study in those that have compensated cirrhosis. There was one study that reported improvement of patient-reported outcomes using CILOFEXOR in patients with primary sclerosing cholangitis. It's certainly nice to include patient-reported outcomes in clinical trials because quality of life is significantly affected, and particularly in patients with cholestatic liver disease. And this study lastly looked at a selective ileoapical sodium-dependent bile acid transporter inhibitor, which will decrease uptake of bile acid and hence hopefully decrease pruritus in patients with cholestatic liver disease. This particular study looked at its role in PSC, and there seems to be significant reduction in the degree of itching, particularly for those that have a higher level of itching prior to being randomized. The only major issues with this class of drug is GI side effect. Since you're inhibiting bile acid uptake, it leads to diarrhea, abdominal pain, distension, which was actually one of the common side effects reported on this drug. Up to 80% of the patients did have some form of GI side effect. So we'll see where that will lead to. So in general, in terms of landscape of clinical trials for PSC, there is a lot going on. The UDCA study is very promising phase 2 data, currently phase 3 in Europe. We've talked about obeticholic acid, good data in phase 2. Hopefully there will be phase 3. CILOFEXOR is the non-steroidal FXR agonist. Phase 3 is enrolling. Fibrates, unfortunately, is terminated. I'm sorry, SELADELPAR, which is a semi-based study, is terminated because of the negative signal seen in patients with NASH. There have been good data on GF19 analog from NGM 282. The last two on the first column are being investigated in pilot type of studies. Anti-adhesive molecules, there is a phase 2 study using BTT102 in Europe. Vedolizumab, though mechanistically we think it would be helpful in PSC because of inhibiting the gut liver lymphocyte trafficking. A retrospective study from the International PSC Study Group has not been positive, but we haven't had a good, well-planned study. Hopefully there will be some in the future. Syncrovirac, which is anti-inflammatory, anti-fibrotic, had relatively positive finding. I think the data was mixed. It was a small study. Publication will be coming out soon. Vanco has been evaluated in children with good benefit. In adult, we don't have a firm data. There is an open study in clinicaltrials.gov currently enrolling. Sulfasalazine is also being investigated in a smaller study, as well as fecal microbiota transplant. So in general, I think in general, the landscape of drug development in patients with PSC and PBC is very promising. You know, targeting disease process symptoms and patient-reported outcomes, which is great. We definitely need to be aware of these studies and know who's at risk so that you can refer them to these emerging therapies or clinical trials. And I think more importantly, emerging validation of surrogate markers of disease progression, as well as prognostic models, have been very helpful in designing these studies. Hopefully that will help us move the drug developments forward sooner, since most of these clinical outcomes actually take many years to occur. For example, liver transplant and PSD is over 15 to 20 years. So having the surrogate markers of disease progression would be helpful for drug development. Thank you.